This is on pancreatic cancer. The topic for the panel discussion is neoadjuvant strategies in pancreatic cancer. With that, I would like to call our moderator, Dr. Joydeep Ghosh, medical oncologist from Kolkata. His panelists, Dr. Prasad Narayan, medical oncologist from Bangalore, who is also our session director, Dr. Sujit Kumar M, medical oncologist from Chennai, Dr. Dipanjan Panda, medical oncologist from New Delhi, Dr. Sanjay Desai, surgical oncologist from Indore, Dr. Ranti Ghosh, radiation oncologist from Kolkata, and if we have Dr. Sudipta Bandopadhyay, medical oncologist from Kolkata, we request you to come on stage as well. So I'll hand over the mic to Joydeep sir. Over to you, sir.
Thank you. So I think all my panelists are there. Dr. Sudipta. Prasad sir, you are not supposed to sit in the panel. You will be. No, you are the chairman. Okay. Yes. That's very useful that now you're sitting there. Okay, so to set the context, we all divide pancreatic cancers into resectable, borderline resectable, and unresectable or metastatic. Now we all know that for resectable cancers, there is no confusion. You straight away go for surgery. If the patient is good performance status, we go for adjuvant chemotherapy, modified FOLFIRINOX. If the PS is borderline, you go for gem, nab-paclitaxel or gemcitabine alone. And this is based on the PRODIGE 24 trial where FOLFIRINOX was compared with the standard treatment that is at that time was gem plus gem single agent. Then came the SPAC4 which was gem plus capecitabine. So that option is also there. And it has shown a significant improvement in the overall survival. Now, if you look at all the subsets, more or less there was a trend towards improvement of OS with FOLFIRINOX. So the standard stays as for resectable pancreatic cancer, we go ahead with the surgery, and for fit patients, we treat them with FOLFIRINOX, or for unfit patients, either the SPAC4 or single agent gemcitabine. There is no confusion about this. Now coming to the borderline resectable. So if you go by the definition of borderline resectable, these are the most common criteria that are there for head lesions. That is, if the portal vein, SMV or portal vein more than 180 degree with contour irregularity or thrombosis of the vein, but with suitable vessel proximal and distal to the site of involvement, so the reconstruction can be done. If there is IVC involvement, if there is a common hepatic artery without extension to celiac axis, the superior mesenteric artery less than 180 degree, and a variable anatomy. So I want to ask Dr. Jayesh. Dr. Jayesh here? Okay, so I want to have Dr. Shaumendash as one of our surgical oncological. Oh, sir is there. Okay. So, sir, in your practice, do you strictly follow the criteria for borderline resectable, which is given in standard guidelines or NCCN and ESMO?
Yes, we follow the same criteria for resecting borderline resectable pancreatic cancers.
Okay.
We don't try to be very bold for directly going for a jump for a surgery.
And in your practice, what is the most common anatomical finding that makes it borderline, usually?
Well,
is it the
there is
arterial involvement?
the arising of the hepatic artery, aberrant hepatic artery is the most common finding. Otherwise, we don't have anything which is substantially difficult for a surgery.
Okay. And for this is for the head lesions, and for body and tail lesions, they have also mentioned that celiac axis involvement less than 180, and they have also mentioned that some institutions will still attempt a resection on patients who have CT evidence of more than 180 degree of celiac axis involvement, on the basis that some studies have shown that this involvement basically represents scar tissue rather than cancer. So will you be comfortable stamping it as a borderline if there is more than 180 degree involvement?
No, I would be not comfortable in that.
Okay, fine. So my question again to you would be, so what proportion of patients come to you with a borderline resectable?
More than 50%.
More than 50%. And what proportion would be roughly resectable, clean cut resectable?
Clean cut resectable on and first look at the CT and the on table resection, 25% will be clean-cut resectable pancreatic cancers.
Okay.
Otherwise, some of the other might be having 30 degree to 40 degree involvement of any of the vein or vascular structure, but
Okay.
not more. If it is more on the previous CT or triple phase CT scan, it is showing 180 degrees involvement of the major vascularity or anything, we just directly send to a medical oncologist, treat them first, then
Okay,
we
so
will
I'm
think of it.
coming to that. Yeah. So next question to you would be, you prefer an MRI or a triphasic CT?
Both.
You do both in the same
Both. The triphasic CT scan is most important for the vascularity
Okay.
and the mapping of it. And MRI will be giving most of the part will be for the pancreatic duct and the lesion of the, what is the status of the biliary tree.
Okay, okay, fine. And is there any need of PET?
No, there is no need of PET.
Dipanjan, any neural PET in locally advanced or borderline?
If you look at the guidelines, there is no data. I just want to supplement with Dr. Desai that we generally call for a triple phase CT, we call it pancreatic protocol.
Pancreatic protocol, yes.
So that particular word is important because many a time the CT scan we don't get all the report.
Right.
And the biliary tree anatomy is actually very important for that.
Right.
PET scan, I think if the metastasis is not there in the liver, it is the chance that it has been metastasis bypassing liver to lung or any other is roughly 1%. So I think safely we can say a good triple phase contrast enhanced CT scan is in pancreatic protocol is the most important. PET is not something we do it, but even if sometimes the problem with PET that many of the time people do PET with a low dose CT or a non-contrast CT that defeats the purpose.
Right.
So I think we should.
Right. And even the CT sections of a PET might not be optimal.
Yes.
PET CT sections are always jumping of 3 to 5
3 to
centimeters.
5, yes, yes.
So
They are
what
not
we
1
need
mm or
for a
0.5.
good pancreatic resection is at least a millimeter to 3 millimeter sections for a good reconstruction and anything else. We cannot judge for pancreatic resections on an PET CT because they jump very high. The sections are very jump. The important part of the vascular involvement is missed when you try to operate on PET.
True, agree. And in case of a resectable lesion, sir, do you need a tissue diagnosis or you straight away go in?
For head pancreas, we don't
Don't need it.
No
So a
need.
radiology showing a CA pancreas is fair enough.
Okay.
And in case of an obstructed lesion, would you prefer putting a stent or that complicates your situation?
In case of obstructing, we just directly go for a surgery.
Surgery.
But depending on the bilirubin level.
Yeah, so did you face difficulty from the anesthesia team regarding the unfitness with a very high bilirubin? Say, suppose I say a patient who's having a bilirubin of 30, 35, otherwise fit and resectable.
Then we
we'll
directly
go ahead.
directly for surgery.
Okay.
I think I'm not a surgeon and Dr. Desai must be, but our surgeons, if the patient has a sort of quite a long-standing obstruction and liver is congested, sometimes they would like to put a stent, wait for some time so that the congestion of the liver decreases. But of course, that is ultimately depends on surgeon. I think there was way back in 2008 an NEJM paper was there which shows beyond 15 they would like to do decompression.
They would like, beyond 15 bilirubin, they would like to do a stenting.
That paper was quite old,
but
it was a
recently up to 18 to 20 bilirubin, the upfront surgery has been planned. But not looking at the most important part is that there's the prothrombin and the liver function. If the liver is very much deranged, then we would not like to attempt for a direct surgery.
And your take on EUS, a preoperative EUS?
US, no.
No, not required.
I
Yes.
want to ask regarding the anesthesia clearance. The anesthesia clearance, is there any issues when the jaundice is very high? Do we have any issues like that?
Basically, they are concerned with the bleeding part only.
Okay.
And most of the drugs which they are now using are safe, they are less hepatotoxic. Therefore, most concern is on the bleeding part and when there is a deranged prothrombin time. At that time only they are much more worried, otherwise they would be happy to give an anesthesia.
Okay. So moving ahead, now considering an unresectable cancer, so I would move to Dr. Prasad. So in this situation, what will be your largely goal of therapy? Will it be changing it to a resectable disease?
Hardly in practice. Hardly I have seen unresectable changing to resectable in pancreatic
So
cancer.
very less
Yes.
numbers. Okay. So in that situation, it will be most likely symptom control and as much overall survival we can give.
Right. So there I think there is a question of to consider sometime CTRT. In
CTRT.
unresectable disease which is locally advanced. That is what most of the patients end up getting.
Okay.
Maybe starting with systemic therapy and then going ahead with that.
Okay.
If I can just add to what Dr. Narayan has said, see, he is very right. I think less than 20% of actual
Yes,
unresectable case
I'll
will
come
become
to the data,
resectable.
yes.
But giving neoadjuvant chemotherapy sometimes gives an idea about the tumor biology. And there has been recently some data which are saying even if not R2 resection, but even if R1 resection in pancreatic cancer followed by treatment can have some survival advantage. These are very early and there is no major trial. But I think like many other, like mostly in breast we have done, the chemotherapy part will be shifting towards neoadjuvant or anterior chemotherapy. You cannot say
yes.
in unresectable disease it is neoadjuvant, but it's an anterior chemotherapy. And one of the big reasons is that it underscores the tumor biology, which will be able to better prognosticate that.
Selecting out that poor subset or the good subset.
Because in PREOPANC study you have seen 25% of them will ultimately progress and will become unresectable, even borderline.
Right.
But that most probably is selecting out that patient who will anyway will have a poor prognosis.
Right. So in same lines, I would come to Sujit that if you have planned for the quote unquote neoadjuvant chemotherapy in pancreatic cancer, anything other than these criteria which helps you decide?
Yeah, so even if we have a resectable pancreatic cancer, post-surgery, it is seen that around 80% do have systemic disease progression and 20% have local disease. So I think all of these are true. Maybe definitely early treatment of micromets is there, biological selection is there. I don't know how much, there definitely the resection in locally advanced cases when we give chemo, there is higher resection chances.
Right.
And also the post-operative leak, biliary leak also has been found to be less if patients have got neoadjuvant chemotherapy. So I think all of them are important for us as a rationale for neoadjuvant.
Sir.
The maximum local failure in pancreatic cancer is locoregional. In the pancreatic bed itself, because of the retroperitoneal and retrocaval areas. At that time, whatever systemic will be very late. Even if after a good surgery on a resectable or an unresectable patients, maximum will be within 6 months. If it is there, it will be in the locoregional pancreatic bed only.
Right. True. So coming to the big question, I'd go from left to right through all of you. It's chemotherapy, chemoradiotherapy, or radiotherapy alone?
Chemotherapy.
Sir.
I think if you go by the recent PREOPANC study, that actually did not show any advantage of chemoradiation. But having said that, that is a broad statement. So in general, most of the study has shown, I think neoadjuvant chemotherapy is good enough. But I think in some selected cases, radiation may have a role. But it may not be a chemoradiation, it may be a post-neoadjuvant chemotherapy if we find that patients still have an unresectability, maybe after that radiation have a role. So, but as of now, most of the major phase 3 data has supported that neoadjuvant chemotherapy, FOLFIRINOX, but recently the SWOG study has shown even gemcitabine and nab-paclitaxel is actually numerically superior to FOLFIRINOX. So some multi-drugs, so the issue is that we need a multiple drugs, and most probably the only chemotherapy is good enough. Addition of radiation, although can have a resectability or overall survival benefit, it did not show.
Sir, do you think that giving preoperative radiotherapy would hamper your surgical
It will.
To a
Because
significant
basically the radiation reaction and the fibrosis around the tumor and in the pancreatic tissue will not help me to have a good surgical margin, cut margin of a pancreas on palpation. On table we cannot be, will not be happy for sending a frozen section at every place for a pancreatic resection to have a negative margin.
Okay. Sir, chemoradiotherapy?
Chemotherapy.
Chemotherapy.
Yeah.
Anupam?
I think it's short course, I mean SBRT after downstaging with some chemotherapy. because otherwise in a pancreatic tumor, giving radical NSCT-RT or radical chemo RT is not going to benefit at all.
No,
So
in a situation where, say, for example, the surgeon tells you that if there is a response, I might be able to do a R0 resection. So in that
yes,
situation, we want
absolutely.
to.
Taking in that counts, say for example, the patient has received 4 to 6 cycles of neoadjuvant FOLFIRINOX. In that case, I would like to give an SBRT to that area. So maybe that will, which is the main crux of the alliance study. So that is where we are all talking about. So maybe, of course, that is where we can go.
Ronti, your take on it?
Yeah, I am agree with Dr. Anupam. Not long course CTRT, it must be SBRT, because during long course CTRT, it is more common to distance metastasis, because pancreatic cancer is a highly aggressive cancer, so chance of distance metastasis become very high. So short course SBRT within a week after good downstaging in a good performance status patient with better sterilization of the margin and good resectability. So my option is SBRT.
Okay, so we come to the evidence of what we have for neoadjuvant chemotherapy. So this was a Lancet 2016 meta-analysis, patient level meta-analysis, and it included almost 355 patients, and the median overall survival from the start of FOLFIRINOX, which was used as the neoadjuvant chemotherapy, ranged from 10 to 32 months, and the patient level median OS was 24 months. This is in borderline resectable or locally advanced, because the selection criteria of these trials were not very strict. And for patients, for the pooled proportion of patients who had a resection was just a meager 26%, and out of which R0 resection was possible in around 80% of the patients. And fortunately, there were 13% of the patients who had a complete pathological response. So I would come to again to my medical oncology colleagues. Have you ever seen a complete response in a pancreatic cancer? I have never seen. I'll start off with myself.
No, I have not seen.
Okay, sir.
No, I don't remember I have seen a pathological CR. We have seen good response, but not pathological CR. I don't remember.
Sir.
No, I have not seen any pathological CR.
Not seen.
Not seen. Okay. So maybe a very small number of patients, or there might be issues with the response criteria also. But anyways, this was a meta-analysis. And again, there was one study published in European Journal of Surgical Oncology 2018, which looked at the neoadjuvant FOLFIRINOX, again in locally advanced or borderline resectable. So there were 30 locally advanced and 23 borderline resectable patients. 10% of LAPC and 87% of BRPC actually underwent a curative surgery. And the important message from this study was that the perioperative complication rate was lower in those who received neoadjuvant chemotherapy compared to those who compared to the historical standards, and also median overall survival was 34 months and 26 months in the 34 months versus 26 months in the control group. This was the British Journal of Cancer publication, recent one, 2020. This is a phase 2 study, a proper prospective phase 2 study. The design was slightly different. So 8 cycles of FOLFIRINOX, then surgery, and then 6 cycles of adjuvant gemcitabine. And the primary endpoint was PFS. Curative surgery was done in 60% approximately, and the median OS again stays at the tune of 2 years, that is 25 months. Also, we have another review of 365 plus patients. Here also they mentioned that the PAT-CR rate is around 7% and the resection rate stays around 28%. This was one important trial because this is again a prospective randomized trial where the design was that patients were to receive 2 cycles of gem-nab-pacli. Then if they had a response, they had to get randomized into 2 more cycles of gem-nab-pacli or 4 cycles of FOLFIRINOX. So it's more like continuing the same regimen versus intensifying the regimen. And the primary endpoint of this study was a surgical conversion rate. And the results show that the surgical conversion rate was 35% in those who received nab-paclitaxel gemcitabine throughout versus 43%, but it was not statistically significantly different. And also the survival was not different between these two arms. So this tells us that from the chemotherapy perspective, if you give gem nab-pacli all throughout versus if you change to FOLFIRINOX midway, it doesn't make a difference. There's same rates of resection and same rates of long-term outcomes. Also, there is LAPACT study, which is again an important study recently. It was again a phase 2 study, 6 cycles of gem nab-pacli followed by treatment of physician's choice. Now, the treatment of physician's choice included either you continue chemotherapy till further progression or toxicity, you go for CTRT as a consolidation, or you do surgery if there is a resectable disease now. So there were 106 patients, around 60% completed the induction, and 44% received the subsequent treatment, out of which 16% received surgery, and 7 patients had an R0 resection, 9 had an R1 resection. The median OS stays again at 20 months. Now, the thing is that the proponents of neoadjuvant chemotherapy, many of them are medical oncologists also. So I would start with, again, Sujit. So do you think that the dismal response rate seen in all these trials of 25%, 30%, so somebody who is having a relatively resectable cancer, do you feel scared of giving neoadjuvant chemotherapy to these patients, keeping this mind that 70% of the patients will actually progress?
No. If you see the stable disease, it's around 40%. So
Right.
I think stable disease plus partial response is around 70%.
Right.
So it is clearly seen that if there is a very good response in the CA 19.9 levels, there is improvement in the GC, the weight is better, the pain is better. They may not still have any response in the scans, but they will be a good candidate for having better outcomes.
Right.
So I think it's not only about the disease shrinkage, maybe they won't shrink much,
Right.
but the final outcomes will be better if the other parameters are good. So I think
you mean to say that there is a lot of soft tissue and fibrosis component also, which
Yes.
can actually
yes, so
lead
the
to a stable
guidelines say
disease?
that even if there is a minimal soft tissue increase, we
Okay.
should not consider it as a progression, and we should consider for surgery if it is resectable. So I think definitely for resectable, there is no doubt currently they are considered for surgery. For borderline resectable disease, if it is stable, there is tumor marker response, there is improvement in the general condition, we should consider it as a positive response and consider for surgery.
Okay.
So I don't think only by 30% of partial response we should take it as a response rate.
Okay. Dr. Deepanjan?
Joydeep, just before I tell about this, I wanted to tell about your chemo radiation.
Yeah.
See, I
you
just
want me to go back to
want
that
to,
study?
you have
Which
shown
one?
too many phase 2 study. I think to be fair on the radiation, we should
Yeah,
have
I'll come to that.
included the Priopanc.
Yeah, I'll come to that,
Huh.
because this is, I'm discussing only the chemo part.
Yes.
Now I'll come to the radiation.
Now that chemo, I think the major study which has final report has not come is the SWOG study. And that SWOG study had shown that neoadjuvant chemotherapy helps, and most probably either you use gemcitabine or nab-paclitaxel, or you use modified FOLFIRINOX. Both are good drugs. And in fact, if you have seen the numerical value of gem nab-paclitaxel is actually 6 months better. Now coming to your response, I agree with Sujit. Do not look at only at shrinkage, you have to look at a clinical benefit rate. Having said that, we all know that pancreas is not the most chemosensitive tumor. Another important part is that the KRAS, the Karsten-Rous sarcoma virus mutation, KRAS mutation, which is about 25% in. So I think the time has come, most probably in the further future clinical trial, there will be chemotherapy with a monoclonal antibody directed, either sotorasib or adagrasib, or somebody along with chemotherapy, or some targeted therapy would be added to get the better response. I think there is a limit to which you may add many. I think triplet is already quite toxic, and beyond that chemotherapy will not help. So we have to find other way to get a better response. Another problem which is seen in borderline resectable pancreas, especially with the vascular involvement, even if there is a shrinkage, the shrinkage is not uniform. So it still, even after a good shrinkage also, it still remains, the area of contact remains same, and the surgeon always finding it difficult. But as I said, even in my previous talk, that even R1 resection, not about talking about R2, But even R1 resection, there has been some data, not a prospective randomized trial, but retrospective trial that R1 resection also may have a better survival compared to not being able to do and only give a palliative chemotherapy. So these are the point when we look at the benefit of upfront chemo, that it shrinks, although not uniform. It gives a better biological behavior, and of course it gives a help to do a prevent micrometastasis. So I think this way, and of course you will discuss the radiation in detail, I believe.
Yes. So, do you bring in CA19-9 value in deciding after neoadjuvant treatment that what do you want to go in? Suppose there is a stable disease and in one patient you have a drastic reduction, in the other patient more or less stable. So, would that help you decide?
No, I will not rely on that. If I were to, means after 3 cycles of neoadjuvant chemotherapy or any with the response evaluation, if there is even a stable disease, I would like to go for a surgery, but not weigh the value of CA19-9 for anything to avoid my surgery.
Okay. So your take on this?
So the first question about the response rate.
Yes.
I think it is there is no other choice. So even if you get a 30% response and 70% disease control, I think it is fine enough, because there is no other treatment which will be offered for this patient at first line. Second is, I mean, we will not take decisions based on CA19-9.
Okay. Anupam?
See, I am a proponent of the fact that the single most curative modality of pancreas treatment is an R0 resection.
Yes.
So come what may, we have to go to a point wherein the surgeon would be able to have an R0 resection. It is only then we will be able to give some time to that patient.
Right.
Having said that, I will always maintain that, whatever be it, if a tumor is chemo resistant, will be radio resistant as well. Because you see head and neck, you see other sites, seldom a chemo resistant tumor will be a radio sensitive tumor. So if after chemotherapy, if we don't see good response, then I don't think we have any role to play further.
Right. Ronti, you'd agree with that?
This overall response rate, basically radiological response, but
Yes,
in post-chemotherapy radiological response assessment is bit difficult. So all may not converted at the same surgical response rate.
Right.
So in this all studies, we can see most of the patient got R0 resection. Even R1 resection, according to sir, that is also be a good prospect. So we can't have said that only 30%. It's converted as around 50% R0 resection. So we have to go with that neoadjuvant prospect. So we can't deny it.
In fact, many proponents have said that even if there is not much of a radiological response, if you are confident, if the surgeon is confident, you might as well go in, because the margins might be fibrous tissue and not active tumor cells. Is that it's embedded within the fibrous tissue. So now coming to what we were talking of, the data of neoadjuvant chemoradiotherapy. So this was a prospective randomized open label multicentric trial, phase 2-3. So here gemcitabine based neoadjuvant chemoradiotherapy of 54 gray, followed by surgery or upfront surgery followed by chemoradiation in borderline resectable cancers. Now it was a small study, around 58 patients, and this was from Korea, and 2-year survival rate and median survival were significantly better in the neoadjuvant chemoradiation than in the upfront surgery group. And R0 resection rate was also significantly higher in the neoadjuvant chemoradiation than in the upfront surgery group. So I would come to Anupam. So do you think that the better, so here what they did is surgery was there, it's anterior chemotherapy versus posterior chemotherapy. So do you think that bringing the chemoradiotherapy earlier, leading to improvement in the resection rates, that is what led to the improvement in survival? Although this is a very small study, we have...
Actually, it is a testimony to their surgical skills also. Okay,
Right.
so the thing is that, first of all, you have to see the radiation dose that we are giving in neoadjuvant. 54 gray is very high.
Standard dose?
54 is high, no. We have to go maximum till 50 gray, not more than that. There is no role of added, dose escalation in neoadjuvant. We cannot go that. So if you have gone there and they have achieved this resection rates, then I would definitely say that it's a testimony to their surgical skills, which is in Korea, right? Okay. So number one. Number two, as you have said, if the very modality, like we give GEM plus neoadjuvant RT, and then add up with adjuvant chemotherapy, it is basically this chemo part in the adjuvant modality which is actually maybe adding to the benefit of the results.
Right. So then we have the PREOPANC trial, which is a very famous study. It was published in JCO. This was the trial design. So resectable or borderline resectable patients with a good performance status, they were randomized into the standard of care, which was upfront surgery followed by adjuvant gemcitabine, versus a neoadjuvant arm where gemcitabine was given for 1 cycle, followed by gemcitabine RT, followed by gemcitabine again 1 cycle. Then the surgery was done, and then adjuvant gemcitabine for 4 more cycles. There were 246 patients, and the R0 resection rate was 71% in patients who received preoperative chemoradiotherapy, and 40% in patients who underwent immediate surgery, and it was statistically significantly different. So the adding of sandwich GEM-CTRT has improved the R0 resection rate in this prospective study, and the median overall survival by intention to treat was 16 months with the preoperative CTRT versus 14 months, but that was not different. So it's very unusual. Maybe you can comment on this, that despite the higher rates of R0 resection, we do not see an overall survival advantage. What do you think can be the reason for this?
As far this trial is concerned, at this time when we have better neoadjuvant chemotherapy protocols like FOLFIRINOX, I don't know how much significant is to have a GEM-RT as a pre-surgery option. So I think the reason it would have been that overall survival has not improved will be because of the distant metastatic rates, maybe more because it would local control and local response rates would have been better. And but the distant control with a intensive chemo is not here in this study. So I think the reason why the overall survival did not change between the study arm and the standard arm would have been because of that.
Now there are many other things which we have to consider. See, first of all, this was a case where there was both resectable as well as borderline resectable.
Yes.
They were, so you have to see the subpopulation, how the resectable work.
There might be differences in the baseline characteristics.
And secondly, see, this is also a very interesting thing that in phase 2 trial, this was a positive trial, but it come to phase 3, if you have read the phase 2, that was a positive trial. But in phase 3, actually, it becomes a negative trial because the primary OS benefit was not there. But if you have to see the subgroup analysis to see how the borderline resectable did, I think they did better than this. Secondly, I think somehow that what our radiation oncology colleagues said that I don't think a long course of radiation is the best. I think the best way to give radiation in pancreas is SBRT, which is a short and hyperdose.
More focal.
Because otherwise that I think if you consider, and thirdly I think with gemcitabine as a chemotherapy component with radiation therapy, it is a little difficult. Most of the radiation oncology colleagues, at least in Apollo Delhi, are a little afraid to use gemcitabine as a radiosensitizer. I think there's a trial which is going on which is use gem-nab-paclitaxel as a neoadjuvant chemotherapy followed by capecitabine with RT.
Yes.
I think that result will come in 2026 or somewhere. I'm really looking for that because I think 5FU or capecitabine is a better radiosensitizer as far as the handling is concerned.
Okay.
So I think and in sometimes and about 20% of these patients during the post neoadjuvant may become unresectable. So maybe although intention to treat analysis is overall accepted, but I think we have to see those patients who has become progressed and could not be operated upon, and a patient who for other reason also could not offer surgery. That part also we have to separate and see how they. So these are the few of the thought about PREOPANC study. Overall it's a good study. And I'm also a little surprised that the DFS and R0, but these are the also positive thing that DFS and R0 was improvement. And why the overall survival benefit we didn't see, you have to really look into the trial and see all those subgroups and
possibly
what are the
as Sujit was pointing out that we do not have a very intense chemotherapy to address the distant.
So we'll have to, I have not seen the what was the percent of distal recurrence and what are the local recurrence in these patients. So those data needs to be seen.
Another thing that
I think
find
I
out-
would like to make a point here.
Yes.
I don't know how much of a difference, I mean, the difference could be using gemcitabine as a radiosensitizer and a capecitabine, which is a 5-FU analog as a sensitizer, because right now you people are moving towards 5-FU backbone based chemotherapy for pancreas. So
Right.
this could be one of the factors which I would believe.
Right. Yeah, what you wanted to say.
And another thing I want to point out that here a long course, when we use long course radiotherapy, or when we get a pancreatic patient, all patients are not so much fit, and radiotherapy regimen when must be there, sometimes we stop radiotherapy and again there is a gap, so long course is very difficult for them to complete in a stipulated time. So there may be a situation when their chance of distance mates and which reflected in the overall survival. So long course may not be a good option for neoadjuvant setting.
Because the more we are, prolonging the neoadjuvant modality, the more we are allowing tumor doubling times. Okay, so we need to cut down on the tumor repopulation that time around. So that is why SBRT scores over a long course RT.
So moving ahead, this was another study where there were two arms. This was the alliance trial that we were recently talking of. So arm A had 8 cycles of neoadjuvant FOLFIRINOX, and arm B had 7 cycles of FOLFIRINOX followed by SBRT or hypofraction. Now I have, and all these patients were followed up with 4 more cycles of adjuvant FOLFOX. So there were 126 patients. I'll come to the results, but before that, I'll come back to Anupam, that between SBRT and hypofractionated IGRT, which one would you choose? And just let us
SBRT
know
is a
why.
hypofractionated IGRT only.
Okay.
SBRT is basically a hypofractionated RT only. It's only that we are using motion management strategies in that. Okay, so the word stereotactic pertains to strict immobilization, so that because we are dealing with an organ which is extremely mobile. Okay, so and it has mobile bowel around it. So we need to take the bowel out of our radiation fields, and that is where we are using SBRT. So you talk of hypofractionated IGRT. So it's basically an SBRT with a stricter margins. So that's it.
Okay.
Pancreas is a fixed organ. It
No,
will
sir.
not. It will not move.
I'll not talk. Sir, I am
It will
talking
not
about the
move.
peripancreatic bit, sir. So where it is
Peripancreatic,
lying, sir, the
stomach,
cyanide.
stomach, colon, and the jejunal part will be affected when
Because
you-
the problem is that when we are using very high dose in SBRT, we have a very high chance of firing the duodenum around. That is the problem. So that is where we have to be very, very careful.
But I didn't understand how would the image guiding actually reduce the chances of a duodenal toxicity, because it is just adjoining.
It is motion management, because that is how our onboard imaging is gives us, because we have to have a strict motion management strategy. If we see that our OAR is coming, if the basic funda is, if we see that the OAR is coming within our tumor field, the machine will not fire. Okay, so the tumor should not, it should be as sub-millimeter precision therapy as we call it. So that is where the motion management comes into the onboard imaging.
Okay. So coming to the results of this alliance trial, so here you can see that surgery after 8 cycles of chemotherapy or radiotherapy, whichever arm it was, surgery was done in 58% of the patients who received FOLFIRINOX, and 51% of the patients who received FOLFIRINOX followed by SBRT, and R0 resection rate was 42% versus 25%, and 30% of the patients actually completed the whole treatment, and only 18% in the FOLFIRINOX plus RT arm completed the treatment. And the 18-month overall survival was 68% in arm A, which is chemotherapy, and 47% in arm B. So this trial tells us that probably adding SBRT over and above FOLFIRINOX might not actually lead to improvement in the surgical rates or the long-term overall survival. So I would come back to Sujit. So do you think that if we are using FOLFIRINOX, have we reached the ceiling of effect of neoadjuvant therapy that additional SBRT is not helping in any way?
Yes, I agree. This study clearly shows that actually there is I don't have to go through the details why there is a detrimental effect. There is a, if you see it's around 68% and 48%, so 20% less. So might be, as I was saying, that there is difficulty for surgeons after
that
radiation.
is probably one of the reasons.
And we have to see what was the post-operative morbidities, whether it has contributed to the survival thing. But I think FOLFIRINOX, when we are using as a neoadjuvant strategy, additional radiation may not be needed. Only if the surgery is not possible at the end of it and still the disease is localized, maybe we can consider CTRT as a completion or a consolidation phase. Pre-surgery, we may not need radiation for making it better.
I agree with Sujit. I not only FOLFIRINOX, I believe is that chemotherapy has reached a ceiling. I also agree that most probably SBRT or for RT is best kept for a post-chemotherapy if we do not get sufficient response and the surgeon wants some more shrinkage for that matter. But you have to remember there is a broader picture that pancreatic cancer is not the most chemosensitive tumor.
Yes.
And it has got some of the mutations for which we do not have. So
suppose,
I think...
suppose I say that this patient is a known BRCA positive. Would you be more inclined to use a FOLFIRINOX, or you would be okay with a GemNab package just because it's BRCA positive?
Well, I think in that case I would like to add platinum.
Platinum.
That definitely for that. BRCA patients known to be platinum sensitive. So that's for sure.
Okay. Prasad?
I think this results are not surprising because most of the radiation when you combine with chemotherapy trials in pancreas have been negative or compared.
Yes.
This is from the type of SPAC trial when we compared the different adjuvant therapies. So somehow there are flaws in all these trial designs because of the lower numbers or whatever, but still I think now we have a very clear data about neoadjuvant chemotherapy surgery in borderline operable and operable patients. I think that will become the standard. As you said, we may have hit the ceiling there actually.
Right. So this is another interesting study. So FOLFIRINOX was combined with losartan followed by chemoradiotherapy. So patients received FOLFIRINOX and losartan for 8 cycles, and those patients who had a radiographically resectable tumor after chemo, they received a short course radiotherapy with capecitabine. Again, small numbers, 49 patients, out of which 86% of the patients actually underwent attempted surgery, and R0 resection rates was around 70%, in line with the previous trials also. And another major study, the LAP 07 trial, where there were 2 randomizations. The first randomization was patients received gemcitabine alone, and in another patients received gemcitabine plus erlotinib. We all know that gem plus erlo is not one of the favorite regimens for medical oncologists, but anyways, this trial was designed long way back. So gem versus gem plus erlo, and in the second randomization, patients with progression-free disease after 4 months, they received 2 months of same chemotherapy or underwent radiotherapy. So it was more like a 2x2 crossover design, and it again showed that there was no outcome. Whatever strategy you follow, either you give gem, erlotinib, gem alone, or you give the same regimen versus converting to CTRT, it doesn't matter. The survival is just the same. So there was no role of any consolidation after primary chemotherapy for locally advanced. So summarizing the role of RT, I would like to, like Anupam, to summarize what do you feel is in today's day the role of RT in neoadjuvant pancreas?
It's only to make the disease resectable, that's it. The little amount of residual disease which the surgeon feels that, I'm not very confident, that is where we step in. Otherwise, that's it.
Okay. And in your institution, do you practice routinely?
Thankfully, I have not, got any such, query from my surgeon. Thankfully, after the neoadjuvant chemotherapy, the cases have all been operated. But having said that, if ever he, feels that it's not being operable, then I'll be happy to take over. But as of now, I have not been, in my 4 years of experience in this institute, I have not got any case which has not been able to gotten downstaged.
Okay. So, just the last section, whether we really need to give adjuvant if the patient has received neoadjuvant before the surgery. So, this was one population-based cohort study where they looked at patients who received adjuvant versus who did not receive adjuvant. And this was, the left side is the unmatched cohort, and in the right side you see the matched cohort. So, definitely there is some evidence that probably giving adjuvant chemotherapy improves the OS after the neoadjuvant. And also they looked at the cohorts of an R0 resection versus an R plus resection, and there also there is some role of adding adjuvant after a neoadjuvant therapy. So Sujit, I would like to ask you, suppose you have given FOLFIRINOX to a patient and fortunately the patient has responded. In the adjuvant setting, what would you give? You continue FOLFIRINOX or you would add gemcitabine single agent or an SPAC4 type of regimen?
No, it depends upon the general condition after surgery, how he has improved.
If the patient has good performance status after surgery.
The recommendation is for 6 months of total treatment. So if I have given 8 cycles or 6 cycles of FOLFIRINOX,
complete it.
Yeah, I will complete it for the remaining cycle, or I might make it FOLFOX for the remaining cycle.
Okay.
I may not. I would like to keep gem-nab-paclitaxel as a second line whenever the patient progresses. So.
Okay. Deepanjana?
I agree with Sujit. After a major FOLFIRINOX, say 3 months of FOLFIRINOX and Whipple surgery, I don't know how many patients would be fit enough to gain another 3 months of modified FOLFIRINOX. So most probably FOLFOX would be a better option.
Okay. And would you switch to an SPAC4 regimen?
Well, I don't think so, because I think if the patient has responded to 5-FU oxaliplatin irinotecan regimen, I would like to continue with that, and I would like to keep the other chemotherapy because if I give gem capecitabine for 3 months, I don't think SPAC will. They say you have to give it for 6 months. So how long would you give? I think I'll keep that peri-operative chemotherapy regimen. And if the patient has shown good response, I would not like to change.
So you're sticking to the 6-month timeline of peri?
Yeah, I mean that's what we get from colon cancer, and we have to follow something, right? It cannot be arbitrary for anything.
Right. So
basically, after a Whipple surgery, whatever chemotherapy, if the patient is performing good and tolerating his diet in a good manner, it is the choice of the medical oncologist whichever drug he wants to give.
But I would ask you one question. Suppose the patient has had a 3-month of gap after surgery. Would you want to start?
No, I would not advise that patient to go for any further treatment, because 3 months of gap will be due to some complications of the surgery. It is not that a patient has been lost to follow-up or something like that.
Okay.
So that patient will not benefit much more.
Dr. Prasad, in your practice, in case of a patient who has undergone upfront surgery, up to what time you would allow chemo?
2 months.
2 months.
Yeah.
So third month?
Third month, I don't think
even
after
if it's
that,
like a T3N2 disease?
I don't think then there is any point in giving adjuvant actually. If somebody has not been able to recover from a upfront Whipple surgery for 3 months, as Sir said, there is an issue.
Okay. But if it might not be a general or a PS issue, it might be some leakage or something like that. A non-oncological issue.
No, if it is a leakage or anything else, that mechanism of systemic inflammatory responses of the body is going to decrease his immunity and everything. Whenever you are going to give any chemotherapy, you are furtherly decreasing the immunity and increase the toxicity of it. The response, the patient will not even come out of the first cycle immediately after 3 months, whichever may be drug you may choose.
Okay.
In such a situation, I think we should do a repeat CT, and many times we might find some progression. So
Cancer
I think
has come. Yeah, this has actually happened in a couple of patients. This has actually happened. This point well taken. So, the future prospects, well, as Dr. Deepanjana was mentioning, there are a series of phase 2 and phase 3 studies which are ongoing, and I'm sure we will have some positive light in this aspect, because this is something that is not hitting that success button for a very long time, the neoadjuvant treatment in pancreas. So this rough flowchart we can follow in case of a very good performance status patient who's borderline resectable, you might consider chemotherapy with either a FOLFIRINOX or a gem-nab-pacli. If there is disease progression, you can consolidate with RT, or you can switch to the next line of chemo. If it is no surgical resectability candidate, not a surgical candidate, you can consolidate with RT. If there is a good response, you go ahead with the surgery followed by plus minus adjuvant. And if there is a poor performance after the systemic therapy, you go for best supportive care. So with that, I would like to conclude the panel discussion. I really thank all my panelists for the wonderful contribution.
Shall I ask one thing?
Sure.
So the guideline says there is role for diagnostic laparoscopy in pancreas. Do you routinely do it?
Sir, at our place, we, after chemotherapy, we, if we find anything suspicious on an CT scan, then we try to do a laparoscopy, otherwise we directly go for a surgery.
I have one question for Dr. Deepanjan. So if it is a borderline resectable CA pancreas MSI high, will you give dostarlimab? I hope we don't.
I don't know.
Actually, I have a patient currently on treatment, not dostarlimab, but I have a 67-year-old gentleman, resectable pancreas locally, but has a 2 centimeter liver metastasis.
Okay.
Now the CA 19.9 was 500, so he's fit, PS1, he was a retired policeman, so he's on FOLFIRINOX. 2 cycles over, it has come down, the CA 19.9 is now 150, 200. Now, is there any role for, suppose it further reduces and at the end of 4 cycles, is there any role for liver resection plus pancreatic surgery in oligometastasis?
This is a very important topic.
Sir, the liver resection will depend on which segment of the liver is there. If it is on the segment 2 or 3 and on the surface, you can just remove it.
His question is, even if it is a nicely removable lesion, single lesion, do we treat a oligometastatic CA pancreas in a curative way like we do for breast
we don't treat like that.
We don't do it.
There is a good response to chemo.
Because in locally advanced
I think both in stomach cancer as well as in pancreatic cancer, this has been trialed with oligometastatic, and at least not with the recent FOLFIRINOX, but with previously historically, it has not shown to be a survival benefit. And your question about dostarlimab, that has raised some ethical questions. See, the way Glaxo handled that rectal cancer data is unethical, immoral, if not strictly illegal. With a 16 patient data, they went ahead and I think all medical oncologists across India at least been asked by 500 patients that there is some drug which has completely cured cancer. So the way they made it a marketing gimmick of a scientific data, we all know what happened. I remember in 2010, that PARP inhibitor, Pancreatic, which was great data in phase 2 and banned, and Mark lost $5 billion on that trial. So on that phase 1 sort of data, the way Glaxo did it, I think they should be held by the medical council. That is not the way science is done. Having said that, yes, we are all impressed by that, but 16 patient data doesn't make...
And another thing, they got it published in NEJM. That is even more surprising.
That is another thing. If you look at the last 2-3 years NEJM publication, most of the major data is done by pharmaceutical company initiative, not an investigator initiated trial. The problem with pharma initiated trial, with no malice to anybody, I will tell you, that investigator initiated trials are much more balanced. Where pharma initiated trials, they will tweak the what is the primary endpoint. So if there is not overall survival benefit, they look for PFS. If there is no PFS, they will do it for something called clinical benefit rate. So tomorrow you will define a new criteria to get your things statistically. So that's not the way science works. So the only way for that is that scientific institutions to come together to make an alliance and to make more and more investigator-initiated trial. The trial goals should be simple. Most of the trials now in statistical jargon is very difficult to read and understand. Whereas you must understand and appreciate that most of the great trials, historically and now, are actually simple to do and simple to understand. So I think we all must sit together and think that what our scientific discovery is going.
True, I can't agree more with that. So with that, we would conclude the panel discussion. Thank you very much.